Welcome to the first joint webinar between the European Sleep Research Society and the European Respiratory Society. We are thrilled to bring together experts from both fields to share insights, foster collaboration, and advance our understanding of respiratory and sleep health. Thank you for joining us for this exciting event. It is also my honor to present to you Professor Pirelli. Professor Pirelli, she is a distinguished specialist in orthodontics and dentofacial orthopedics and serves as a professor at the University of Rome Tor Vergata, Italy. Renowned as a pioneer in orthodontic treatment of children with obstructive sleep apnea, Professor Pirelli has dedicated her entire career to advancing the health and well-being of children. Her work focuses on the growth and the development of maxillofacial complex and the intricate relationship between orthodontic therapy and respiratory function. Through her groundbreaking research, Professor Pirelli has demonstrated the critical role of orthodontics in the interdisciplinary treatment of children with obstructive sleep apnea, establishing new standards and protocols that enhance both dental and respiratory health. I'm confident you will enjoy Professor Pirelli's lecture. Professor Pirelli, the floor is yours.
Thank you, Karen. And I'd like to thank all the organization and especially Dr. Karen Spruitt for this kind invitation to speak about my work on rapid maxillary expansion. Are you able to see my screen, my presentation?
Not yet.
Now?
Not yet. Yeah, it's coming.
Thank you. Thank you. So my work on rapid maxillary expansion in the treatment of OSAS children. First of all, I have no conflict of interest. Sorry, just a minute. Oh God. Okay. Then the aims of this model is understand the biological basis of the procedure of rapid maxillary expansion, understand the role of this therapy in the treatment of OSAS children, the skeletal effects and the consequent functional improvement, and then gain knowledge of the clinical indication and benefits of this treatment in the multidisciplinary treatment of OSAS children, with the functional effects supporting its efficacy in the long-term outcome. In 2002, after 20 years of orthodontic practice, we presented the rapid maxillary expansion in OSAS children for the first time. Then Christian Guilleminot, Dr. Guilleminot, was there, invited me to present RME in the treatment of OSAS children at the World Congress of Sleep Apnea in Helsinki in 2003. And the first time of this topic in OSA World Congress. And we were the first with Dr. Guilleminot to publish this topic in the Journal of Sleep. And after that, many researchers have conducted studies on this subject, confirming the importance of the topic. Above all, I'm really happy that many OSAS children are benefiting from this therapy. Today, in fact, RME has been recognized by the scientific community as an important contribution to interdisciplinary treatment of OSAS children. It's interesting that at the time of our first presentation in OSA field in 2002, in the report of the American Academy of Pediatrics, the first line treatment for OSA children was adenotonsillectomy and CPAP for non-surgical candidates. And after 10 years in the following technical report, American Academy confirmed rapid maxillary expansion as a valid and alternative treatment. For a long time, Dr. Guilleminot, the father of OSAS in children, underline the importance of a multidisciplinary collaboration in the treatment of sleep disorder and breathing. In Paris in 2006, he emphasized that orthodontic and craniofacial abnormalities related to pediatric OSAS have been overlooked until that time, despite their impact on public health. And in Tallinn, in Porto Alegre in 2014, and Tallinn in 2015, he emphasized the elimination of oral breathing is the valid finish line in pediatric sleep disorder breathing. And in Rome in 2017, the last Congress before he died, he was for one time supporting my idea. One more time, I really want to thank him. RME is a procedure that we are successfully adopted for many years in all cases in which we want to obtain a skeletal expansion of the upper jaw. And as I introduced this topic in OSA field, I want to remember the biological basis of this therapy, its skeletal effect, because these are the reasons for the functional improvement in OSA children. Then I show you our long-term follow-up study. Rapid maxillary expansion is based on the possibility to intervene through orthopedic forces and special procedures on the mid-palatal suture. I was very interested in this maneuver, so I deepened my study on the mid-palatal suture. And this is our lab specimen of the mid-palatal suture for a better understanding of this anatomic structure. Here you can see lamellar contact bone, and in between, highly vascularized fibrous tissue. At the higher magnification, tissue features become more evident. So lamellar contact bone, and in between, this typical tissue, very reactive to the distraction. That's, I believe that rapid maxillary expansion is the best treatment for children which present a constricted maxilla that will lead to nasal dysfunction. A clinical example, a typical face of the oral breather. The profile clearly shows the flattening of the mid-third of the face, with labial incompetence, the typical nasal features, and the intraoral examination, we can see a bilateral anterior crossbite due to insufficiency of the upper jaw. That's important. And the upper and lower arch, and you can see a typical pattern of ogival palate. Here, the expansion sequence, the appliance for RME, bonded molars used as an anchor. The molars are only an anchor for the expansion screw. The teeth act as an anchor through which orthopedic force is applied to the bone structure, allowing the opening of the mid-palatal suture and the increase in width of the maxilla. It's not a dental movement. In the frontal view, we can appreciate the suture opening and the changes in the cross-sectional and sagittal relationship. In the lateral view, pre and post RME, you can appreciate the changes in the transversal and the sagittal relationships. And we can see the skeletal expansion caused by the maneuver occurs not only in the maxillary arch, but also in the nasal cavity. We can appreciate a tangible cross-section increase in both upper jaw and nasal cavity. Moreover, we have to consider that RME can also increase the oropharyngeal space, modifying the restive posture of the tongue. So, because of all these reasons, we have thought that RME could be an effective treatment in OSA children. And our first study demonstrated the positive impact of RME in the treatment of pediatric OSA patients. The first prospective study on OSA children treated with rapid maxillary expansion. In this study, we investigated 31 children affected by malocclusion characterized by narrow upper jaw with oral breathing, not due to dentofacial hypertrophy, snoring, and nighttime apneas. Patients underwent an orthodontic investigation, ENT visit in T0, T1, and T2. Orthodontic investigation was performed using X-rays ENT visit with rhinomanometry, audiometry, and polysonography. And after RME treatment, polysonographic evaluation in T2 demonstrated further improvement with significant difference not only in T1, but also in T2. And the total expansion effects consist of a downward-forward movement of the maxillary complex with a resulting increase in all directions in the nasal canal. A substantial increase is reported at the cross-sectional level with a relevant improvement in the nasal airflow. And these movements can also indirectly improve the oropharyngeal space by modifying the resting posture of the tongue. Here you can see the cephalometric assessments before and after RME. You can see the anatomic changes in the whole sample. All cross-section diameters increased at intermaxillar and intermolar level. Nasal cavities and interincisor space increased in width. So our first results demonstrated that RME therapy has a positive impact on children affected by bronchopathy and mild OSAS. In case of sleep disorder breathing, it's important to evaluate the state of the maxilla and consider RME because a change in the anatomic structure brings about a functional improvement. With these results, we announced at the time that the orthodontist can play an important role in the interdisciplinary treatment of OSAS children. After 12 years, from our first study, we wanted to evaluate if RME was an effective treatment in the long-term therapy of OSAS children. And our paper is the longest follow-up investigation of OSAS children treated with RME to prospectively evaluate the long-term efficacy in a selected group of children. So we generated data by evaluating objective and subjective evidence over a 12-year follow-up period. From our sample of 31 patients who were in our first study, we enrolled 23 patients in our follow-up study. This was performed at 12 years after the end of RME treatment. All subjects underwent an overnight polysonography. No patients examined had recurrence of the symptoms or signs associated with sleep disorder breathing after the onset of puberty. Some subjects had no follow-up. 6 boys were studying abroad, and 2 girls didn't want to be part of this study. This is a reality of clinical practice. So 23 patients represent the reviewed group for the follow-up study. No patients presented ENT problems. No subject had injuries during the 12-year period. None of these subjects were obese. We had been cautious in our approach in the first study, selecting only children without enlarged adenoid and tonsil, and all children were Caucasian. So after RME treatment, as we said before in the first study, the apnea-hypopnea index decreased and the clinical symptoms had resolved by the end of the treatment period. And 12 years after the end of the treatment, in the follow-up study, no significant changes in the apnea-hypopnea index or in other variables were observed. So these results show that RME is confirmed as a useful approach in children with malocclusion and OSAS, as the effects of such treatment were found to persist for a long time after RME therapy. But to achieve these results, it's essential to realize the expansion, the skeletal effect. And in this our study, we demonstrated the skeletal changes after RME evaluated by computed tomography, CT. In fact, to avoid relapse and recurrence of symptoms, we have to change the anatomic structure and to retain the expansion achieved. A clinical example, the extraoral view, and in the intraoral view, the evidence caused by to do insufficiency of the upper jaw. The upper arch shows the typical pattern of a ogival palate due to basal contraction of the upper jaw. And here you can see the expansion sequence in 14 days. The CT scan showing the sutural opening and the opening of the mid-palatal suture in the palatal view in the volume rendering. And we can see the real skeletal effects. The widening of the nasal fossa and the septal release, restoring normal airflow. It's this very anatomic change which brings about an increased patency of the upper airway. That's the foundation for the positive effects induced by the maneuver also on the respiratory function, with a net improvement of breathing disorders during sleep. And the functional improvements are clearly linked to the skeletal expansion, since in our sample, the positive effects were found to persist for a long time. We want to verify the skeleton condition in a follow-up study. Here you can see the long-term follow-up of the same patient. The palatal view in 3 different stages. We can see the stability of the obtained result and the reorganization of the suture. The study of the base width confirms, as you can see, the long-term stability of the expansion. And in the specific scan of the mid-palatal suture, we can see the reorganization of the suture. The organization of the suture at the mid-palatal level. And we can see the improvement in sinusal ventilation. This is very interesting for all of you. This improvement in sinusal ventilation is clearly documented by the progressive disappearance of the phlogistic fluid retention. These effects start immediately after RME, as we can see in the central slide. And in the follow-up, we can not only see a maintenance of this effect, but we can also see a net improvement. The CT scan shows in the right sinus, so we can verify a fuller restoration, and in the left sinus, a small osteoblastic reaction of the bone wall persists, but without any increase after a long time. This is evidence of previous inflammation. Then we studied the distance of the pterygoid processes. And this distance shows the real skeletal changes in the bone structure after RME. This is a very important scientific evidence because in the past, this movement was impossible to demonstrate by use of traditional X-ray examination. And now CT imaging allows us to verify this movement caused by RME. This increase reconfirms the skeletal effects induced by the maneuver that lead to a real remodeling of the craniofacial structure. And the follow-up is a very important evidence that confirms the stability and the maintenance of the anatomical changes induced by the maneuver. Finally, here in the volume rendering imaging, we can see all the sequence and the long-term follow-up. These images clearly show the important skeletal effects induced by the maneuver and their stability in a long-term evaluation. This is why rapid maxillary expansion should be considered essential within a therapy protocol for pediatric patients affected with OSAS. It's always important to assess the condition of the upper jaw in order to consider RME therapy in the multidisciplinary treatment of OSAS children. Because the change in the anatomic structure, RME brings about a functional improvement. So our study demonstrated that the functional effects of the treatment were found to persist for a long time after RME. This is the longest follow-up investigation of OSA children treated by orthodontics. So RME is confirmed as a useful approach in children with malocclusion and OSA, as the functional effects of such treatment were found to persist for a long time after the end of rapid maxillary expansion. So to conclude, the follow-up study by CT imaging confirmed the stability and the maintenance of the anatomical changes induced by RME. That's clearly linked with the stability of the functional improvements. So the orthodontist can really play an important role in the multidisciplinary treatment of OSA children. So take-home messages: rapid maxillary expansion should be considered essential in the therapy protocol for pediatric patients affected with OSA. We must assess the condition of the upper jaw in order to consider RME in the multidisciplinary treatment of OSA children. Because changing the anatomic structure, this therapy brings about a functional improvement. So to conclude, we demonstrated the real changes induced by RME and their stability in the long-term follow-up. Because changing the anatomic structure, RME brings about a functional improvement. To avoid relapse and recurrence of the symptoms, we have to really change the anatomic structure and to retain the expansion achieved, also performing myofunctional therapy and respiratory re-educational training therapy, because interdisciplinary collaboration is absolutely fundamental. So, thank you very much for your kind attention.
So thank you, Professor Pirelli, for demonstrating us the critical role of the orthodontics in an interdisciplinary treatment of children with OSA, and for your work during your career with proposing new standards and protocols to enhance both dental and respiratory health. And this brings me back to Stijn. So
thank you, Dr. Spruit.
Thank you, Paola. Good evening from my turn. It's my pleasure to introduce the second speaker of this joint webinar. This is Professor Maria Pia Villa. She's the head of the Department of Pediatrics at the University La Sapienza in Rome. Within the ERS, she has been one of the pioneers of bringing more attention to the field of pediatric sleep disordered breathing, and she's a real clinical and research expert on many topics in pediatric obstructive sleep apnea, but also with a focus on orthodontics and dental sleep medicine. So she's the ideal speaker to talk about the evidence of the effects of orthodontic treatment on sleep apnea-related morbidity in children. So Maria Pia, you have the floor.
Yes, thank you. Thank you, Stijn. Thank you to invite me to this interesting argument on the treatment of sleep apnea in children. So, the definition of what we consider OSA is just to focus on the aspect that we usually speak about sleep disorder breathing, because the obstructive sleep apnea is just the top of an iceberg, but other clinical findings like snoring, upper airway resistance syndrome, and obstructive hypoventilation are the entities that induce the same consequences and complications as obstructive sleep apnea. That's just to point that all these aspects must be treated in what the treatment you want to use, and in this case, the orthodontic treatment. This is a typical aspect. Paola showed you some of these aspects: long face, under dark circles, oral breathing, lip hypotonia, nasal cartilage hypotonia, and facial dysmorphia. We have the constriction of the nasal pharyngeal. This obstruction are very, very important aspect, because one most important aspect in this time of the life is the children with OSA have enlarged tonsils and adenoid that induce a nasal constriction, and allergic rhinitis can help to induce and increase nasal constriction. But this aspect induced to nasopharyngeal obstruction, and we have the first symptom is mouth breathing. Mouth breathing induce the lower tongue posture and the alteration of mandible and stomatognatic apparatus structure. Let's do very rapidly to alteration of stomatognatic structure with malocclusion and alteration with divide, and the aspect that Paola showed you very well. Mouth breathing is an imbalance of pressure between lip and the tongue, and this is a causes, the majority causes of abnormality in dentition and in maxillary form. Of course, the first symptom are oral breathing and nasal obstruction that we must carefully take in attention to start very early the treatment. This is the facial cranio-respiratory complex. This is just to show you with strict relationship there is with mouth, volume of mouth and upper way airways. This is a normal structure with cranial and respiratory complex, but look carefully what happens when we have this very, very different aspect of profile and structure in children. This is a child at age 4, at age 20 mouth, and in the gestational age. You can very early in fetal life have a sort of indication what kind of development we can have in these children during the life, which is normal, because we know very well a lot of problems we have with OSA as a consequence, as a complications, and a very early interception is important. In this case, in fetal life. Of course, we have some profile that come from two-dimensional ultrasound images, and you can see very well that the A feature 3 that we consider more safe advanced in obstructive sleep apnea. But according to anatomical structure, we have the different airways aspect, different breathing pathway, and I just repeat: nasal obstruction, oral breathing, and sleep apnea. This is just a feature more relevant in children with obstructive sleep apnea. They are maromaxillary and dental arch, longer lower anterior face, stepper, gonial, and posterior inferior angle and alteration. This is just to show you the Pierre-Robert frequencies is the top of the iceberg that can conduce to craniofacial anomalies that you now know very well. In 2020, this systemic review and meta-analysis show very well the effect of obstructive sleep apnea in children treated with rapid maxillary expansion, where they collect 100 children, and what they show that we are in all cases the reduction in obstructive sleep apnea. And if you related to the size of tonsils, in this case, you show very well that the more improvement, the bigger improvement is in children with no tonsils or in children with small tonsils. That means you can choose which kind of treatment you want define first and second. or adenotonsillectomy or rapid maxillary expansion related to the sizes of tonsils. This is a roadmap for the treatment, the multidisciplinary treatment, just to show you that the rapid maxillary expansion is a part, but the devices could be very useful. And of course, in the first year of age, we can use the devices and rapid maxillary expansion later. We might have surgeon intervention, myofunctional treatment, and a very long follow-up, because the history, the natural history, can start again to analyze, restructure the aspects of the mouth. This just to show you that that if you are not very early intervention in the life, we can have some consequence. In this paper that published in European Respiratory Journal, using a sleep clinical record just to focus on some clinical aspects and symptoms, you can see very well that in school age children, you have malocclusion, nasal septum deviation, and high overjet, where in children in preschool age, we have only nasal hypotonia and mouth breathing. That means mouth breathing and nasal hypotonia obstruction induce, if we didn't treat very early, the consequences of alteration, the skeletal alteration. What happened in adolescence? In adolescence, we must take into consideration the BMI, because in this study, the author can and yet demonstrated very well that the hip circumference and BMI is important to define the benefit of skeletal modification, because BMI and lip circumference, according to some aspect of structural alteration, induce more or less the improvement in sleep apnea symptoms and in apnea index reduction. Just to say, but what happened in the outcome of the treatment? Not all patients have the same reduction of obstructive sleep apnea. You can see in some slides that where the range of decrease of apnea index was very large. That means there are some subjects that responders and some other subjects that responded not so well. That means they needed an integrated therapy, could be. For example, in this case, in these 40 children treated with moderate adenotonsil hypertrophy and were treated with rapid maxillary expansion at time 0 at time 1, we can show that we have children that we define responders when the apnea index decreased more than 20%, and no responders with the apnea index decreased less than 20% of time 2. And what we observed that was strictly related with the some orthodontic in RX parameters. That means we can previously know which children could be as successful in this treatment and which child have no successful in the future. There are some evidence of the effectiveness of treatment in adult patients, because we have not a lot of evidence in general, but in this case, what's happening in adult patients? In this paper of 2015, the author analyzed, meta-analysis review, a comparison with CPAP treatment and mandibular advanced devices in some parameters related to cardiovascular situation. In this case, they observed the change of blood pressure when the patient are treated with CPAP or with MAD. And they found that there are the same efficacy. CPAP and mandibular advanced devices obtain the same decrease of, for example, in this case, the blood pressure, systolic blood pressure. And the same happen in other vascular aspects, in endocrinology. This is really a narrative data that come out in the literature, where the author demonstrated there are an improvement in circulatory system, blood pressure, heart rate, variability, and in some endothelial functions. So they demonstrated that in the majority of cases treated with MUD, the patients had clinical improvement in symptoms and in functions. That means that there is a place for MUD in adult patients related to some aspect very important like cardiovascular aspects and for example, cognitive function and depressive symptoms in adult. Just some animal models I won't show you because it's very important. This is a very new paper come out in the literature where the researchers study the TNF-kappa-B, that is a pro-inflammatory neurotransmitter, and the authors very well demonstrated that after treatment, orthodontic treatment with rapid maxillary expansion, rabbits show a decrease in this neuroinflammatory target and modify the alterated myocardial anatomical aspects. This is just to show what happened after MUD. The apnea-hypopnea index and the oxygen saturation come back to the normal value compared to the control. This is another aspect that the researchers study. Then when they put the MUD in a rabbit with sleep apnea, that exhibit higher pulmonary arterial pressure, comparing to the control, the researcher demonstrated that the media thickness percentage of pulmonary artery was higher in the OSAS group and decreased after MUD introduction. This is a picture that shows nicely what the author tried to demonstrate. This is the pulmonary vessel before, and this is a pulmonary vessel after treatment with appliance. But not only in this aspect, but if you look at another aspect, that is the apoptosis, neural apoptosis in frontal cortex. That is a consequence that we can see in children with sleep apnea, but in this case, the author demonstrated that MUD in rabbit with OSAS had a reduction of neural apoptosis after MUD therapy. Look very nicely where there are the reduction of number of apoptosis neurons. What evidence on effectiveness in dental treatment in children? In this paper on 2021, the author looked at the orthodontic features, increases mandibular angle, skeletal class 2, increases of overbite, lower jaw retrusion, and retracted tongue, and they demonstrated with these different types of treatment, they have an improvement in decrease in apnea-hypopnea index, ameliorating the desaturation and improve the efficacy of the sleep. So the craniofacial anomaly must be taken into the consideration. I'm sorry, I don't know, I arrived just in the, okay, sorry. Okay, this is just to explain the paper that I showed you before in terms of type of anomalies. I'm so sorry. Okay, so This is another paper that the author study with PSQ and OSA 8 group children with and without obstructive sleep apnea, and pre-rapid maxillary expansion and post-rapid maxillary expansion. There are decrease of somnolence, behavior, corner scale, and Epworth scale, the efficacy of sleep. And of course, apnea-hypopnea index ameliorating, and the LP PLMs decrease. No, the okay, this go. I don't know. I go directly to my conclusion. Okay. I'm sorry, but I try to use. No. I'm so sorry. Okay. So come back to the last slides. This is a paper that comes from Guilleminot, that they study that there are some anomalies in oropharyngeal growth in infancy and in early childhood that contribute to significant sleep disorder breathing in children. And recognition of oropharyngeal structural anomalies is associated in apraxia in childhood may permit timely intervention that avoid the progression to sleep disorder breathing on OSA. What is apraxia? Apraxia is an alteration of tongue movement that induce an anomalous development of stomatognatic apparatus. The apraxia could come from the genetic and environmental aspects. Of course, the prematurity is the starting point for all these manifestation of alteration of tongue movement. But if you look at the genetic, for example, short frenum is the most important aspect that induce abnormal orofacial growth, maxillary mandibular deficiency, and mouth breathing. And prematurity induce hypotonia and mouth breathing, where environmental through allergies, reflux, and the largest turbinate induce an abnormal nasal breathing and mouth breathing. In this line, there is this paper that demonstrated the short lingual frenum is an abnormal situation that starts early in the life and is strictly related with sleep disorder breathing and sleep apnea early in the life. That means we must carefully observe lingual frenum starting from the first month of life, of course, early in the life, if we have not take into consideration to cut the lingual frenum at the moment when we observe. This is a paper from Guilleminot in European Respiratory Journal that show very well that there is a possibility to measure the length of the frenum in order to have an intervention at the right moment. In this paper that we published in the Sleep Medicine in 2020, we demonstrated that the short lingual frenum is a risk for sleep disorder breathing, but through the alteration of a right development of mandible, maxillary, and stomatognatic apparatus. And you can see very well where the tongue, the strength of the tongue is one of the most important points. That means apraxia or reduction in the movement of the tongue for oral breathing, for example, is one important risk factor. After this, we try to have a question: could we influence this aspect using myofunctional therapy in order to increase the tone, the force, the endurance of the tongue, and stop the alteration related to the tongue hypotonia? They studied two groups of patients that are the same aspect in order of tongue strength, peak pressure, and endurance before and after myofunctional treatment dedicated to reinforce the tone. We study this type of strength, peak pressure, and endurance using the YOWA. This is the YOP measurement. It's an instrument with a bubble that the child put upper behind the incisors, and through the pressure of the tongue, we were able to measure strength, pressure, and endurance of the tongue. What we observed that after myofunctional therapy, we had, of course, a reduction oral breathing like hypotonia and the abnormal tongue position, increase of the saturation and decrease the low saturation during the night. And in the group treated respected to group untreated, we have in terms of men's tongue strength, pressure, and endurance, the improvement. You can see here tongue strength, peak pressure, and endurance respected to children with didn't receive the myofunctional treatment. In this non-controlled study, the author just take into consideration what happened after the treatment associated on symptoms and behavior disturbances when the child were treated with rapid maxillary expansion. This is PSQ results, and this is OSA 8 results. You can see that after maxillary rapid expansion, the symptoms in terms of psychological, on sleep-related and sleep disorder breathing related improve very well. So this preliminary study suggests that the improvement in, for example, restless. You know, restless is very often in adolescents, less more than in children, so associated with obstructive sleep apnea. And we obtain the reduction in restless after treatment with rapid maxillary expansion. So you can see the improvement of symptoms, the scale, psychological scale, Epworth scale, and obstructive sleep apnea, lips movement, and saturation during the night. So just arriving to my conclusion that the craniofacial anomalies must be taken into consideration early in the life. Diagnosis and treatment must be early. There are evidence that rapid maxillary expansion determines an orthopedic effect upon the maxillary, improves the rebound of lingual position, increases nasopharyngeal volume, stimulates maxillary complex growth, and increases nasal breathing in children suffering from OSA. All children with sleep disorder breathing need a personalized and precise treatment, and it's very useful to decide the stepwise of the treatment started for medical, surgeon, and orthodontic treatment. Thank you very much.
Thank you, Maria Pia, for this great overview. We have several questions in the chat. We will try to combine them for the discussion. We have 10-15 minutes left. I think that both of you made it very clear that children with sleep disordered breathing need a personalized treatment approach. But could you make some clinical recommendations for the pediatrician or the pediatric ENT who sees a variety of children with sleep apnea? how would you make the flow for an orthodontic or a dental evaluation and treatment, both in let's say otherwise healthy children, and also for children with underlying genetic syndromes, for instance?
Okay, big question, Christine. Okay, so of course the pediatrician could be a first doctor that the child refer, and the parents refers for some alteration of breathing during the night. And in my mind the pediatrician might have a lot of information to decide, first of all, what kind of diagnosis the child need, for example, just a questionnaire or just oximetry during the night, and looking very carefully, and sometimes using, for example, sleep clinical record that we know very well because it's a sort of joint of clinical symptoms and anatomical and clinical findings. This questionnaire could indicate to the pediatrician which is the problems. For example, if there is tonsils, nasal obstruction, adenoids early in the life, orthodontic alteration, and so on. According to this, after the first diagnosis, the first tests, for example, an oximetry, they must decide which kind of professional features is a referent feature. For example, if, of course, we have adenoids and tonsillar hypertrophy, we need to go to the ENT specialist. And after this, if we have residual OSAS or we have the persistent symptoms, could be we have other aspects that we can consider. For example, alteration of structure. In this case, the orthodontist, pediatric orthodontist, is very useful to decide which kind of treatment the child needs. Rapid maxillary expansion, mandibular advances, this is a part of orthodontist, of course. And the pediatrician must start very early to use, for example, medical treatment, because in the waiting time, sometimes it is not so short. For example, in Italy, we have a long time to wait for refer the specialist, ENT specialist, orthodontist specialist. In this case, pediatrician or the doctors who are involved in sleep medicine or in respiratory problems must know very well. This is very important to start early, use medical treatment, steroids, Montelukast, what you want, or nasal wash, and so on. And in the waiting time, to choose the specialist that we can refer, ENT, orthodontist. Of course, myofunctional treatment is base that we can start early, because to rehabilitate nasal breathing could be a corner, as you show before, to stop it, the development of alteration that increase the risk of obstructive sleep apnea.
Okay. Perhaps another question, if rapid maxillary expansion is indicated, there's a question in the audience, what is the best age, or does it depend on the clinical situation? And perhaps a small part of that question, is it well tolerated by children? There's also a question about whether it is painful or not.
No. A rapid maxillary expansion is indicated as soon as possible, as we have the collaboration of the children. The limits depends on the child's ability to collaborate. As Dr. Villa said very well, before a certain age, we can perform myofunctional treatment, but when the constriction, the maxilla constriction is severe, we have to perform a rapid maxillary expansion, and then we can follow with myofunctional treatment. So we have to perform as soon as possible rapid maxillary expansion. In severe case, I try to start around 4 years old. In children of 5, 6 years, I manage very, very well, and the results are excellent. And there is no painful at this age. We can have a little bit painful later in the age, around 9, 10, if it's necessary, you know that it's important. And moreover, I want to say the limit may also depend on the ability of the family member also to understand the importance of the therapy and support the child. In children, you perfectly know we have a lot of variables. So it's fundamental, the role of the pediatrician. The role, the ability of the pediatrician to convince to address the patient to the orthodontic specialist. And I want to underline, please, that as to be an orthodontic specialist and expert in sleep disorder too, possible, but not a general dentist. General dentist has a very important role as a diagnostic sentinel, but he knows, general dentist knows the therapy, but only the expert orthodontist can perform this therapy. And this is the only way to have results, to really have skeletal effects and results, and the following results. I hope to be in time and to, if you have some other questions, some more questions.
Yeah, I think in terms of the age, also the question came in terms of what is the oldest age, so as early as possible, but what is really the limit to really as an age range? Do you have a suggestion on
the limit is the puberty. The limit is puberty. So now you know that later after puberty we can perform RME with surgical assistance, but it's a different. The mechanism is the same. It depends from the age, because we are not only the maxillary mid-palatal suture, but the circummaxillary suture. So after puberty, it's not indicated to perform rapid maxillary expansion without any surgical assistance. But the mechanism is absolutely important, and it's important to act as soon as possible in young age, early age.
And maybe very briefly, very shortly, what about really syndromic cases in those children with deformities, in those children with neuromuscular disorders? Any clinical hint that you can give?
Yes. We can perform a rapid maxillary expansion in any case in which we want to obtain a skeletal expansion of the upper jaw. So also in syndromic situation, at a certain age, 4, 5, we know perfectly, the pediatrician know perfectly the situation of the patient. So if the patient needs it, we can perform rapid maxillary expansion, sure.
Okay, so on my end, I would like to thank both speakers, and for sure ERS for the technical support. And I personally believe that we have made a first of hopefully many to come. And I leave the last word to you, Stijn.
Thank you. I think it was a successful first edition of this joint webinar, and I couldn't agree more that I hope indeed this is the first of many webinars, so that we can bridge the distance between both societies, because I think that pediatric sleep is a global priority, and I think that's the main message for tonight, that we that everyone involved in pediatric sleep, that we have to consider it as a holistic approach, and really aim for a personalized, multi, and perhaps also transdisciplinary approach and treatment for these children. So I would like to thank Karen, I would like to thank Professor Pirelli and Professor Villa for their excellent cases. I would like to thank the audience for the interesting questions, and the people behind the scenes at the Sleep Research Society and the ERS for their technical and administrative support. Thank you very much.
Thank you.
Thank you all.
Thank you, Stijn. Thank you all.
Bye-bye.
Good night.
Bye.
Bye.
Bye.